Good morning, everyone. For those who don't know me, I'm Vijay Daniels. I'm the Associate Chair of Education and Faculty Development. Norman, our chair, is on a well-deserved vacation on a beach, and normally we have the divisional director for the division presenting weigh in, but she is also on a well-deserved vacation on a beach. For those who know the hockey reference, you can consider me your EBUC, your emergency backup chair today. But I'd like to begin with the treaty acknowledgement. I respectfully acknowledge we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. We again have our all-star cast of our infectious disease docs presenting today, and I'd like to go through their biographies. First, we have, not presenting first, but first on my list, Dr. Stephanie Smith, who's a professor in the Division of Infectious Disease. Dr. Smith is a professor at the University of Alberta and Director of Infection Prevention and Control at the U of A Hospital in the Mazankowski. She obtained her MD at Dalhousie and completed her core internal medicine training and infectious disease subspecialty training here at U of A. She then completed a master's in ClinEpi at U of T and did clinical infection control internship at Mount Sinai Hospital in Toronto. She served as a program director for the infectious disease training program for 9 years and continues to be involved in education and mentorship in ID and internal medicine. Her research interests include surveillance and prevention of nosocomial infections, including respiratory viral infections and those associated with antibiotic-resistant organisms. Next on my list, we have Dr. RobynHarrison, clinical professor in the Division of Infectious Disease. Dr. Harrison works as an ID doctor both at the Grey Nuns and U of A Hospital. She's a communicable disease consultant for AHS Workplace Health and Safety Program, a position she's held since 2008. Dr. Harrison is keenly interested in policy development and support for clinicians to prevent infection transmission in healthcare settings. She's a member of the Alberta Advisory Committee on Immunization, and she participates in infection prevention working groups in the province of Alberta, including the past work on the pandemic influenza H1N1 in 2009 and avian influenza in 2014. At the national level, she works with Public Health Agency of Canada as a member of the Prevention and Control Occupation Infections in Healthcare Settings Guideline Working Group. She's a member of the National Advisory Committee on Immunizations, NACI, and she's a vice chair for the NACI Influenza Working Group and member of the High Consequence Infectious Disease Working Group. Dr. Lynora Saxinger is a professor in the Division of Infectious Disease. She trained at the University of Saskatchewan and the University of Alberta and had fellowship time at Harvard University and the University of Zimbabwe. Her clinical portfolio of infectious disease include HIV, HCV, tropical medicine, and stewardship, and is based at the University of Alberta Hospital. She has a variety of roles in the faculty and within AHS as medical lead of antimicrobial stewardship, Northern Alberta, and currently as co-chair of the Scientific Advisory Group, SAG, for the COVID-19 Emergency Coordination Center. Current career interests include antimicrobial pharmacokinetics, pharmacodynamics, stewardship, and resistance, emerging infectious diseases, and knowledge translation. So with that, I'm going to hand it over to Lynora, who's presenting remotely, and then she'll hand it back over to our other presenters here. Please begin.
Thank you very much for the introduction. I'm calling in decongested up from my virally infected home, and which is weirdly topical, I guess. The disclosure slide summary is really mostly consultations and kind of, if anything, federal stuff or unrestricted CME stuff, no pharmaceutical conflicts. And I mean, we're starting to talk about respiratory viruses. So we're all aware of this, but it's quite dramatic to actually see. This is a slide that shows what was going on with influenza right up until the very early part of 2020 when everything changed. And it had been kind of a broad but pretty solid influenza period with influenza for confirmed cases that likely were going to be on their way up. And then everything absolutely plummeted. We had our first mini peak of COVID, then another peak of COVID, then our Alpha, Delta, and Omicron waves there in red. And then you'll see at that last bit, we had our overlap of influenza plus Omicron. And then more recently, our COVID numbers in terms of confirmed cases have remained quite stable overall, if not drifting down. But we had that massive and very abrupt influenza spike in the fall, which came down quite quickly. So that pattern is rather atypical, I'm going to have to point out, because usually we have our flu seasons impacting the hospital somewhere between kind of December and February, most commonly. And this is busy, but it's kind of useful to look at. Now, the top is the lab positive specimens. And of course, we know we don't test everything, but the trends are usually quite reliable year on year. And I kind of took out some of the viruses, some of the smaller print respiratory viruses, but just to point out that flu A is in this aqua color and that we would have flu A spikes every year at slightly varied times. And then we had this disappearance of influenza, followed by this funny little blip in the summer when there was increased connectivity within the population. And then our usual, quote, usual seasonal influenza spike this past fall came kind of early and quite aggressively. If we're kind of wondering about the testing volumes, in the bottom graph, it's the gray bars are the testing volumes. So obviously we were looking harder for things during that time period. One of the things that's really striking to me about this is if you look at that, you think, well, everything went away but the purple. What's the purple? And the purple is actually rhinoenterovirus, which I suspect what I have right now. And it really didn't care about pandemic precautions. It kept on marching right on through. And then we had like this strange series of everything coming back in a very different pattern. Now, the one that garnered a lot of attention is RSV, which on these graphs is this gross brown color. And RSV also came back quite early, then faded away with some funny kind of more constant presence, and then had quite an aggressive peak shortly after the influenza A peak. So this was an interesting phenomenon. And I'm just going to point out that there was I was on call a lot, so I wasn't paying total attention, but there was some really strange controversies, including into the, traditional media as well as social media, and bad terminology being bandied about with the notion of immunity dead. It's not my favorite choice of words, but somehow it became the case that if you recognize that a light RSV year, for example, is commonly followed by a more intense transmission year, it became equated with being a COVID denier on social media, which was a weird phenomenon. And there was a lot of people giving opinions that this is just not what was happening. And I think the prevailing theory was this was related to COVID damaged immune systems being more prone to infections like RSV, which is a hypothesis that currently doesn't have much supportive data. I'm going to just point out that, anyone who dared to say this got in trouble, but the phenomenon of alternating intensity of transmission is very well known. It's been known for years. Matter of fact, some of our valued colleagues here in Alberta had a very nice publication about this in September 2021, showing the seasonality of respiratory viruses at northern latitudes. And you can, kind of throw other things out as much as you like, but there seems to be a very clearly alternating pattern on all these graphs. And it's RSV, it's human metapneumovirus, and then all four of the endemic coronaviruses do exhibit a similar pattern. And it's partially due to seasonal factors, partially also due to the duration of, protective immunity that you get after having one of these viruses, especially for the coronaviruses. So people were looking at this type of data and trying to figure out what the future might hold. We still don't know, obviously, but it is a possibility that we would look for a similar pattern with the SARS-CoV-2 virus. So back to flu, it also varies, but it's not the predictable or more predictable variation of these other respiratory viruses. This is just showing you how much the peaks have varied over time. This is late 2022. Our hospitalization peak was the highest earliest peak since 2015. All these other lines are other years. So I think that that's quite notable. And there's a lot of variation here, obviously, in terms of the hospitalization peak, which usually follows the case peak. And that's because influenza changes it up. So just looking back at the same kind of period of time in history, this top bar is the H3N2 hospitalizations, and all the colored lines are zoned, so you don't have to pay too much attention to them. But H3N2 was really big in 2017, and then down here is influenza B. That was a fairly biggish B year as well. 2018, H1 was the headliner, the pandemic strain H1 from 2009, and then there was a second smaller H3 peak. So it was a little bit more equivalent between the two. 2019, we kind of had three things circulating with no discernible pattern, really. And then 2020, everything disappeared. In 2021, we had that kind of wee touch of H3 that wasn't terribly high impact. And then 2022, H3 kind of came back angry, and there's a touch of H1, and we haven't seen much B yet, but I'll be honest, I'm a little nervous about what's going to happen because everything seems a little bit mixed up. And just remembering that, whenever we've had pandemic strains of influenza, it's been due to reassortant viruses. And because influenza A has multiple different species that can infect, that happens when there's genetic segments being reassorted within some host and development of new viruses that can spread easily. And so H1N1, which, was a pandemic strain, it wasn't a terribly severe pandemic at all in retrospect, although it did definitely have an impact, was a reassortant that had 3 different swine elements, an avian element, and a human influenza element. And it was quite new, but it was not terribly severe. So this kind of just got to mention One Health example, like things like antimicrobial resistance and similar are also One Health issues. Any zoonotic diseases are, but animal health, human health, and the environment are intertwined and interdependent. And so we do tend to have these things siloed when we look at them and when we do surveillance of them. There has been a move to try to make that more cohesive. And influenza is a great argument for that because influenza A viruses are endemic, of course, in waterfowl and domestic poultry and swine and horses and dogs and bats and humans. And there's quite a few different strains going around. The pig strains actually tend to be somewhat similar to human strains. Horse and dog strains are a little different. And then the avian strains are the ones that everyone is nervously watching for quite a long time now in terms of pandemic potential. And surveillance is very important. And that would be something that's been hitting the news again lately. There's usually avian influenza around to varying degrees with varying strains, but for the last 12 months plus, maybe even 12 to 18 months, there have been increased intensity of global bird outbreaks, and easily 2 times that. I was trying to find cohesive numbers and it's difficult, but 2 times that of 2015-16, which was also a rough year for avian flu. And there's been multiple spillover events into mammalian species, which always makes people extra nervous. Suggests, we're looking out for viruses that would then be able to spread more easily in humans based on their receptor specificity. And there's been ongoing influenza deaths in wild bird populations and domestic poultry across North America, Europe, Asia, and Africa, including in Alberta. Canada geese and ducks, and also hawks, owls, crows, and skunks have been affected in the past year. And then there was this attention-getting outbreak on an American mink farm, because it was quite severe. And there was a combination of characteristics that made people a little bit more anxious about that. This strain was still also tamiflu susceptible, but it's concerning. Now, I think there is a bunch of doomy kind of literature about this, but the truth again lies in the fact that there's attention to the avian flu threat all the time, and it deserves that attention. And this is just a map from the National Wildlife Health Center in the US, and it shows outbreaks in commercial, non-commercial poultry, and wild birds and wild mammals. And there's a lot, actually. There's quite a bit. And I'm just going to point out that flyways are important when you're looking at the spread of viruses. And what can happen is things can come across in one flyway, reassort where the flyways overlap, because there's tremendous overlap, and then start going up and down across the continent. Which accounts for some of the strangenesses that we see in spread sometimes. This does have some food price implications, actually, and there's an obvious health risk question. Food production has, the egg production at the end of 2022 had decreased by 30%. They'd had to cull 40 million hens, and the prices had, over doubled in many places for eggs. And it's also looking like it could be a threat to poultry, like meat farm as well, so food animal production. And human health risks so far, not a huge issue. The CDC had, for example, tracked 500 people who were directly exposed through their workplace to avian influenza. They found 1 case, but I'm going to say preparedness seems really wise. And there was a recent report of a fatal H5N1 case in Cambodia in a child. Most of the human cases of avian flu have really intense exposure, and it can be a very, very severe illness with high mortality, but it does not so far seem to spread person to person. Now, I think, however, a bit of healthy paranoia, if there's such a thing as wise. You know, when you look at what happens, there's a lot of avian flu around. And I'm just pointing out that in this graph of all these countries, H5N1 epidemics are in green. And it's just a smattering of stuff going on, and that needs to be tracked. So 2 last slides. What's going on in influenza vaccination? People get real tired of shots lately between COVID and influenza. It's a really common question about how much do I have to keep on getting these shots? Now, I'm going to point out that they save lives and it's worth it, but you know, there is like some reason to think that a longer lasting, broader strain coverage influenza vaccine would be very, very welcome for sure. For one thing, it means that you don't have to guess as much when you're trying to figure out what the strains are going to be. And there's an example of a vaccine here, which is a nanoparticle influenza vaccine for multiple flu virus strains. The goal is to have long-lasting immunity. It's quite cool because it displays part of the hemagglutinin proteins on self-assembling nanoparticle scaffolds, which sounds kind of sci-fi. And there's 4 copies of 5 strain epitopes, which actually elicits a very good response. It seems to be as good as the seasonal matched influenza vaccine response in animal studies. There's human studies that have started with a limited number of people looking at antibody titers. And nicely and happily, this also elicited protective antibodies to 2 influenza avian subtypes as well, this broad vaccine. Now for therapy, there's not too much to say, so it's not going to be too long, but I'm just going to point out that our oseltamivir and zanamivir are the available antivirals to us. There's other agents that might be available elsewhere and could become available here. All of them are best used very early. Because influenza, of course, syndromically is so much like everything else. If you have a high-risk patient, it's usually advised to start empiric treatment and get the test concurrently. That's a real challenge right now operationally because of co-circulation of so many viruses. And I'm going to point out that, for many healthy people, the oseltamivir vomiting and nausea effect might not be that popular. So it depends, I think, a lot on risk profile and, willingness to have potential side effects for risk reduction. There's been a lot of controversy over the years as to widespread influenza therapy is actually worth it. And data over the past 5-10 years had been, suggested that it reduced the time to first alleviation of symptoms by 17 hours without a compelling difference in hospitalization, verified pneumonia, and all these other secondary bacterial consequences. And there is increased nausea with a number needed to harm of 28. Prophylaxis is a little more solid. It reduces symptomatic influenza in participants. Prophylaxis is usually offered in settings like healthcare or long-term care with a high-risk population. And so that remains something that's commonly done. And most of the guidelines across the world suggest treating people with chronic medical illness, pregnancy, extremes of age, severe immunosuppression, and that it really is best if you start within 2 days of onset, even within 12 hours of onset, which I think probably happens almost never unless you're a known contact. And there's a protocol for a clinical cost effectiveness study written in July 2018 that said antivirals are not often prescribed in primary care because clinical and cost effectiveness has been insufficiently demonstrated by non-industry funded and pragmatic studies, which I thought was a little bit funny. Some newer data, though, there seems to be maybe a better benefit than I expected in higher risk patients, and it might be cost effective in some settings. In this study in primary care, 52% of the cohort ended up having lab confirmed influenza. There was a mean benefit of 1 day in terms of time to recovery. In people who were 65 or older, there was a benefit of 3.2 days. And depending on how you look at the cost analysis, it might be worth it. If you exclude the cost of the drug, it definitely saved on some healthcare burden, which is important. And it would become cost saving at a 50% decrease in price for adults and adolescents from a healthcare payer's perspective, with a willingness to treat of $64,000. So in summary, influenza reliably causes health system strain in peak seasons. Reassortment's always a risk. There is progress on new vaccines. Oseltamivir might be more, I'm a little bit more pro oseltamivir than I used to be. And, this is just a real big argument that it is important for us to redesign our systems to keep track of all of these things because the future is to some extent unknowable. I'm going to hand it over to a colleague.
So thanks very much, Lynora, and thanks for having us for yet again three-part round series. So I was saying to Lynora and Robyn that I kind of feel like I got the short end of the stick because I am once again presenting on COVID, whereas the others get to present on somewhat diverse topics. So as I said, I am once again presenting on COVID. I really have to say that I think I struggled a little bit with this particular rounds more than I had in the past, just because I think we're in kind of a strange time right now in terms of the kind of transition or the change from endemic to pandemic, or sorry, from pandemic to endemic. But I'm going to go through a little bit about kind of the current landscape. We'll talk about the current recommendations for therapy, which have, I think, become somewhat simplified. And then I'll just have a brief kind of discussion about PPE a little bit into the future. So I think many of you are in this world where we're kind of living in two different spaces. So, here we are in the community, people are going to hockey games, there's no mask, people are going out for dinner, life is going on as usual. And then we walk into the hospital and this is what the hospital looks like. So it certainly seems like we're still in a pandemic in the hospital, and yet in the community, life marches on. And it can be a little difficult, I think, to kind of rationalize what we're doing in these different spaces. And, you can look at a number of different metrics. This is from the CDC, but certainly I think a lot of countries and a lot of provinces within Canada are trying to figure out what metrics we should be using in the community to guide our decision making. And so, again, this is kind of one idea of metrics. But I think that, whatever metrics you use in the community, they're fraught with difficulty right now in terms of really being able to evaluate them with respect to action on a community level. And so I'll go through a little bit of that, but from my perspective, I think right now we're really looking at individual prevention behaviors in the community, and that's about it, because we really don't have a lot of kind of community level prevention strategies at this point in time. And so, again, some of the metrics that that the community is looking at or public health is looking at are things like vaccination. And I don't have the fourth dose on here, but I think the reason I put this slide up is just to show you that, when we look at vaccination uptake, then we can see that really since April of 2022, so, close to almost a year ago, we really haven't moved the needle a whole lot on vaccination. And I can tell you that about a third of those who have had a third dose have also had a fourth dose. So again, certainly there's been uptake of the fourth dose, but it's dwindling, which so I think that, although we can continue to promote vaccination as a way of protection, again, we're not really moving the needle a whole lot at this point in time. But, having said that, and this is where I think this is all kind of fraught with difficulty, is that doesn't tell the whole story, of course, because then you also have infection-acquired immunity. And so you really have to look at that in combination. And, we can see that, so this lower black line is our infection-related immunity, and then the top line is the combination of vaccine and infection-related immunity. And clearly that's going to change over time as some immunity wanes from vaccine and some immunity wanes from infection. But overall, we really do seem to have quite good we have high seroprevalence, suggesting a fair amount of population-based immunity. And so then the wastewater. So, we've used wastewater. We're trying to figure out how to use wastewater to kind of get an idea of community transmission, how much COVID is circulating in the community. And I think it can be helpful to a certain extent, but it's difficult to use this to make decisions on a community level, mostly because if you look at every different zone in the province, let's say, or even, across the country, there's huge variation over time. And so, you could look at this and say, well, yeah, it seems like we're kind of starting to go down in Edmonton, but I can tell you, if you look at, the North Zone, then we see that there's, another spike. And so it is, you could use this maybe to guide your own personal behavior, but to actually make decisions on a provincial level or a national level, I think it is quite difficult. So in the community again, and I'll talk about this a little bit later, I think we're really left with, we're probably not going to have a lot of kind of community-based strategies, especially related to the non-pharmacologic interventions, so masking and that kind of thing that has, we don't have any restrictions at this point in time, and I suspect that we won't again unless something changes significantly. But what about what's going on in the hospital, where clearly we do continue to have a fair number of pharmacologic interventions. So, here we are, this is Canadian data, and this is number of patients hospitalized, so in the ICU as well as on the wards over time. And although this is maybe a little bit misleading in that it includes patients that are just COVID positive by PCR, so not necessarily admitted with COVID, but admitted and have a positive test as well. But you can still see, it certainly continues to be a significant burden on our hospital system. And in terms of variants and what we're seeing, we have seen an increase in recombinant variants. You may recall in the kind of late winter or late December, early January, there was a lot of concern about some of these recombinant variants and being more transmissible, but it hasn't really ended up causing a significant spike like we had seen before. So it does appear that our waves are becoming less and we're kind of getting to a steady state. However, COVID still really does pose a significant burden on the healthcare system. And I just put this up. This is just over a month. And again, this is data from Public Health Agency of Canada through our Canadian Nosocomial Infection Surveillance program. And so this basically just tracks patients of all ages with laboratory confirmed viral respiratory illness. So the red line is COVID hospitalizations. The purple line is RSV, the blue line is influenza, or the dark blue line is influenza A, and then influenza B. We haven't really seen much of a spike yet. So you can see that COVID still really does predominate in terms of burden of illness. And certainly we did see more influenza. The RSV here is really driven predominantly by PEDS cases. So this is all ages. If I showed you the adult only graph, then influenza would actually predominate over RSV. But you can see still COVID seems to be the predominant virus that is resulting in hospitalizations. And so who are these people that are still hospitalized? Because certainly in the community, for most people that are otherwise healthy, they're not getting severe disease. And this is a study from the UK, but I think certainly highlights what we're seeing here as well. So age certainly is a significant driver of more severe infection. But I would highlight the two kind of top things here, and I apologize, this is really small, but solid organ transplant, renal transplant, bone marrow transplant. So in other words, immune suppressed patients really are the patients right now that are suffering the most from severe disease. And I think all of us see that in the hospital every day. These are patients that get COVID and they can't get rid of it, and they're infected for long periods of time. And so these, are the truly vulnerable patients. So, I think overall, in terms of the current landscape, mortality has decreased over the course of the pandemic, even for those that are hospitalized. We're still seeing higher than normal rates of hospitalization for compared to other respiratory viruses. But really the hospitalizations are being driven by those who are older, very comorbid. And I would highlight those severely immune suppressed patients are really the ones that we need to be very, very careful with. We've seen, not much of a change in mortality in that population, even over the waves. And so when you compare Delta to Omicron, mortality has decreased significantly for almost every population except for these severely immune compromised. So I'll turn to our current guidance for treatment. And this is, again, thanks to Dr. Saxinger, who lent me a few of these slides. So these are just some kind of general kind of guidelines. Antiviral therapies, whether you look at COVID or influenza, certainly are best started within the first 3, maximum 5 days of symptom onset. They work better early. People still do need to test with early symptoms. So, for COVID, obviously we have a rapid antigen testing, but with the co-circulation of all these different viruses, it makes it important to be able to identify if you actually have COVID. And I'll talk about some of the data of antiviral therapies in the highly vaccinated population. Certainly, it's harder to study this because severe outcomes are certainly less common overall now that we have a fairly highly immune population. In terms of the treatment recommendations, they have been simplified mostly because most of the monoclonal antibody therapies are currently of limited use because of decreased neutralization activity for the current circulating variants. So things like sotrovimab, Evishield really aren't effective or recommended at this point in time. We've used dexamethasone for quite some time now, and that still should be the case. Hypoxic patients should get dexamethasone. And certainly if you have patients that are becoming more hypoxic, looking at things like, ARDS and requiring mechanical ventilation, tocilizumab or baricitinib should still be used. So let's look at data for our antiviral therapy. So Paxlovid studies. So the initial randomized control trial, so the EPIC-HR and the EPIC-SR, so this is standard risk and high risk, certainly showed a reduction. The EPIC-HR showed a relative reduction risk of severe outcomes, and mostly so hospitalization, and it was fairly significant. So again, a relative risk reduction of 88% is pretty good. Looking at 6.3% patients hospitalized versus 0.77. So you're looking at a number needed to treat of 18. Now, the caveat to this, of course, is that these were not vaccinated patients, and this was in July to December 2021. So that was kind of pre-Omicron. The EPIC standard risk really did not show a statistically significant reduction. And that's probably because, again, these are standard risk patients where their risk of severe disease is much lower. And so again, a much higher number needed to treat. So let's fast forward to our situation right now. So we have a fairly highly immune population, and we have Omicron circulating still. So what about Paxlovid in this situation? So there's 2, I think, quite good studies that have just been published this year. One in CMAJ from a group in Ontario, and these are both cohort studies, so they're not randomized control trials, but this cohort study looked at a very large cohort, so close to 200,000 people, and they had almost 9,000 patients that were treated with Paxlovid. The rest were not, and they did basically a weighted odds ratio and calculated number needed to treat for a variety of subgroups. And so I think, you can see that this is fairly small, but you can see that the vast majority of these dots are favoring Paxlovid. And when you look at the number needed to treat, if you're less than 70 and don't have significant risk, then a pretty high number needs to treat of 181. So you could argue that maybe that's not cost effective, but certainly for many of these higher risk groups, then it's a fairly low number needed to treat. And again, these are patients that were given Paxlovid in the Omicron era, they were vaccinated. So again, this is probably similar to our population right now. And again, so you can see that overall, if you've been vaccinated, even, but if you haven't been vaccinated, certainly even a higher risk reduction in terms of severe disease. And then this is a smaller study, but again, published just last week in Clinical Infectious Diseases. And this is again a retrospective cohort study. And basically it was a matched cohort study, and they looked at 1,130 patients that received Paxlovid versus propensity scored matched group that did not, and really showed a very similar risk reduction. So 45% relative risk reduction in a composite outcome of emergency visits, hospitalization, or death within 30 days. And then they looked at a number of secondary outcomes, pneumonia, using healthcare, utilization of healthcare with radiologic diagnostics, cardiorespiratory symptoms, et cetera. And again, basically showed that there was a risk reduction. And these are high-risk patients. So again, these are patients that have comorbidities. And so in that group, certainly, I think that there is data to recommend Paxlovid. And so I think that, and I'll, for treatment of high-risk patients, I think that there is good data, even in the Omicron era and even in those that are vaccinated, although, again, you're going to see slightly higher number needed to treat in that population. So what about with other outcomes? And again, thanks to Dr. Saxinger for this slide. So there's really not a lot of data on time to recovery. So you saw Dr. Saxinger's data around influenza and reduced time to recovery, and data on transmission reduction. So certainly, giving an antiviral therapy, you think that you would reduce the amount of virus circulating in a person, and that would result in less transmission. Again, we don't really have data to support that. It's obviously intuitively attractive. And then the data on incidence of long COVID. So again, I think that there is some compelling data around vaccination preventing the incidence of long COVID, but really there's not a lot of data to suggest that Paxlovid actually reduces the incidence of long COVID. So in summary, Paxlovid certainly is indicated in high-risk outpatients within 3 to 5 days of symptom onset. I think it should be considered in inpatients who have hospital-acquired COVID that don't qualify for other therapies because they don't have severe disease, so they have mild to moderate disease, but they're high risk. Those are certainly patients that you could give Paxlovid in. But again, just to remind people, it is contraindicated in transplant patients due to drug-drug interactions. So this is a population that really needs to be treated with remdesivir. And again, I'm not going to go through all of this, but this is what Alberta considers to be high risk. The criteria for Paxlovid treatment across provinces is a little bit different. So some provinces have chosen to interpret the data more broadly. So high risk basically is almost anyone. But in Alberta, this is the agreed upon definition. So when do we use remdesivir? It's really considered kind of our in-hospital antiviral. Again, for high-risk patients with drug interactions prohibiting Paxlovid or moderate COVID within 7 days and as an outpatient. So certainly there does appear to be a survival benefit based on the Solidarity trial and less need for mechanical ventilation from the CATCO study. And there is the Pine Tree trial, which was done in outpatients, looking at early treatment. And again, there is a reduction in hospitalization with a number needed to treat of 22. So I think for the most part, I think most of us are using remdesivir in the hospital. Most provinces do have a referral pathway for outpatient, and that is primarily being done for our severely immune compromised patients, transplant and hematologic malignancy patients. So for those who have severe COVID-19, so again, all hypoxic patients should get dexamethasone. If they're hospitalized and have severe COVID, then they should be getting remdesivir and dex. Obviously, if they have cytokine storm and they're heading toward that critical illness, baricitinib or tocilizumab. And if they're critically ill and receiving mechanical ventilation, then dex and toci or baricitinib. All right, so I'm going to wrap up with, where are we going? So I started with, this kind of, we have this juxtaposition of really doing not a whole lot in the community. And then in the hospital, we're still, basically in a kind of pandemic era where we're continuously masking. We have a number of other non-pharmacologic interventions that we're trying to keep in place. So what's the right answer? And I think it's difficult. I think that, we certainly are moving very slowly to an endemic situation, but, we have a situation where we continue to have really higher than normal hospitalizations related to COVID. And we have a population in the hospital that almost, not 100%, but probably 85% of them would be considered high risk. So I think that, we certainly need to continue to collect surveillance on community prevalence, especially around circulating variants. And I think that's where wastewater surveillance is really going to help us, because we've developed ways where we can actually look at circulating variants in wastewater. And so I think that will be very helpful going forward. I think we need to continue to refine our use of antivirals and immune modulators for those that are at high risk for severe disease, with a particular focus on the severely immune compromised, because again, as I've alluded to, these are patients that are still at incredibly high risk for severe disease and death. I think it's a bit up in the air about whether or not we're going to be having a yearly vaccine boosting based on circulating strains. Certainly sounds familiar from COVID, but I mean from influenza, but I think we're really not quite there yet. So, when I think about what I do in the community versus what I do in the hospital, I think you really have to look at it from two very different lenses. So in the community, the primary focus is that you're assessing your individual risk. And that may take into account the risk of those around you. So, if you live with someone that's at high risk for severe disease, then you might be taking more precautions. But if you're someone that is not at risk for severe disease, then, you might really not have to take a lot of precautions in the community. You might look at prevalence in the community, vaccination status, circulating strains, those kinds of things to affect your individual behavior. You might think, oh, I have a trip coming up, so I'm going to be a bit more careful because I don't want to get sick when I go on this trip. You might, some people choose to mask on planes because that seems to be a higher risk activity, but those are all really kind of individual decisions about your own individual behavior. When you come into the hospital, to me, it's a little simpler because, yes, we look at, the prevalence in the community, obviously, and that reflects the prevalence in the hospital, but really, we're just looking at the risk of those around us, and that's high, period, right? So there's no getting around that. And so we really have to have a completely different set of rules in a way in the hospital than we do in the community. And so that's why we have this juxtaposition. When you walk in the hospital, you're seeing patients that are all at high risk, basically, for severe COVID. And, I think, we've always thought of masks as protecting healthcare workers from patients, but really, and that's still true to a certain extent, but I think we're also really in an era where we really need to protect our patients from our healthcare workers. We know that there's asymptomatic transmission. And so in these situations, then the masks certainly, masking of healthcare workers certainly will help to protect our patients as well. Is there going to be relaxation of continuous masking everywhere in the hospital? The short answer would be yes. It is being looked at. The timing and everything is still, I think, a little bit up in the air. But I think there's always going to be masking around patients as a way to protect patients. And so I think we can see that that's probably not going to go away entirely in the future. It may change slightly, but I think we really do have to look at the hospital setting as very different from the community. And I will end there and let Robyn start.
So I have the good fortune, since Stephanie said she wasn't keen to talk about COVID a third time, I get to do something different, and I'm going to speak about respiratory syncytial virus. So these are my declarations of interest. I do sit on vaccine advisory committees. I don't think I have a conflict of interest with today's presentation, and I'm excited to speak to you about this. So what about RSV? And this is adult medical grand round. So this is not a topic we talk about all the time. I think I've mentioned through these lecture series that I've picked up quotes through the pandemic. I like what people are saying. It helps me and helps me to stay positive. So thanks to everyone. This one is from Dr. Nathan Zelius, leader in our respiratory virus program at our amazing Alberta Precision Lab. The viruses are back on track. When I asked him about epi of our viruses not that long ago, and when I said, "Oh, that's good, I'm going to quote you," he said, "To be clear, it's not good." Of course, unless you're the virus. But I want to focus on this. So we're going to talk a bit about RSV in the next short while. And Lynora has already presented in her section the big picture view in our province. It's amazing that the viruses, with the exception of enterovirus and rhinovirus, disappeared for a solid period of time. And it just shows you the power, I think, of those non-pharmacological interventions that we've never seen before. So it's been quite a remarkable point in time. But I think she was also alluding to, and certainly I wanted to mention this hypothesis about viral interference between viruses, the idea that your immune response to one virus will temporarily and probably interferon-mediated protect you from another one, and that this might drive the pattern of other viruses. And so it perhaps shouldn't come as a shock that seasons are pushed a little one way or the other after such an extreme time. It's beyond the scope of this, but it's totally fascinating. And I found this comprehensive review from one of our amazing Canadian scientists out of Laval, Dr. Guillaume Boivin, and this colleague, Jocelyn Piret, is really good. So if you're interested, I refer you there. We're going to hone in on RSV. This is a single-stranded negative sense RNA virus from the Pneumoviridae family. And it has a predictable seasonal pattern. So unlike COVID-19, which is at a high level and sustained now and still hasn't established, the SARS-CoV-2 still hasn't established seasonality, RSV does. The typical pattern is late fall and winter, and especially when you look at Alberta data, January, February. And that is what we saw this year, back on track. The interesting point about this, though, is we hear a lot, we talk a lot, and it's critical that we do talk a lot about the severe morbidity in children, especially young children under 1 year of age. It is a major problem. And globally, in fact, that extends to death. So when you think about things that we can do to prevent RSV, you have to think about death in infants, especially in lower and middle income countries or areas that don't have access to intensive care that we do in, say, an urban center in Canada. And I just want to put that out there because we need to think about how we can help globally make this better if there's going to be tools in the future. But older adults probably and almost do need more attention as well. And so if we don't, you can see how we may not have tested as much for RSV compared to, say, influenza, where we have treatment, or SARS-CoV-2, a whole other, many reasons there. But we haven't always tested our adults. In Alberta, we've done a lot of testing with a multiplex PCR, but not every province or area has. So I think it has been sort of underappreciated how much disease. Think about your frail populations. I see a pulmonologist in the audience. Think about the frail elderly, cardiovascular complications that happen after respiratory viruses. Lots to learn and probably not teased out yet. This is really important because what I'm going to share with you is that there are things looming on the horizon that we could prevent these viral infections, and it may have way more impact than we realize. Most people are infected very early in life, first 2 years, and then infected repeatedly. So this is just a snapshot from the Public Health Agency of Canada Flu Watch surveillance data, just to show you the gray is kind of seasonal 6-year average, what you would expect. You see surveillance week 7, so that's in the new year, right? Just at the end of February, the bump and it's coming down. And you see this year in the dark blue. So, okay, we're a little earlier there, but basically the similar back on track pattern. There has been variation across provinces, and there are every year. There are variations in testing, as I've just mentioned. More people right now, I think, are using multiplexes. This is something that's coming out of COVID-19, so that's going to help us. We're going to learn a little more about flu, RSV, SARS-CoV together. And so but it's important to look at percent positivity to kind of help balance that out. So I'm just showing you here the prairies were a little different than what's happening in BC, but you see the percent positivity there. We've kind of passed our peak and coming down just under 10%. So zooming in Alberta, I guess Lynora didn't like the brown race car color. I heard her say yucky brown is RSV, so I pulled out the RSV. But what I want to show you, this 2016 to 19, we had pretty consistent testing patterns over that time period. That's where we used the respiratory panel, mostly people coming to emerge or being admitted. So medically attended, RSV, pretty consistent pattern. 2016 was a outlier. But this year and last year, although we have double the number of cases this year, when you look at percent positivity, they've essentially been the same and seasonal. So RSV kind of came back last season and it's here this season, and we're coming down as we would expect back on track. The second point I want to make, it's common, as I mentioned, we probably don't realize how common in the elderly, and it's expensive. I have to gently tease these authors fondly. I'm so grateful for this publication and the work they do. Several of our Canadian experts on this paper, including one of our pediatric ID physicians. So when I'm teasing them about extremes of age, because it's 60 and over. So I don't know if we consider 60 an extreme of age anymore, but the point is those under a year and those 60 and over, bimodal, this is what I want to emphasize, there is bimodal distribution when you look at severe disease from RSV. Most people get a cold, but as Stephanie pointed out, when you're immune compromised, that especially with transplant, that's a totally different scene. It talks about the risk worker to patient, and also when you're older with this virus. So this paper, I won't get into the details because we're tight on time, but it was a case control study, and they did their best to pull out not only the lab confirmed RSV, which I just showed you, but also medically attended respiratory illness that could be attributable to RSV based on those national percentages. So they've calculated it. And then they attached a price tag to it and showed that short term and over the course of a year, these are expensive infections. I'm sure it doesn't come as a surprise to this audience, but it's helpful when you start to think about, if we have interventions, what's the cost, what's the benefit, and what are all the impacts that we might have, favorable impacts. This is from their paper. Simply to show you, the blue bars are total numbers of confirmed cases. The bimodal, I just want you to have an image. The young, yes, but also look at the 65 plus, and it just starts ramping up. So when we're testing, we have a problem in adults as well. And you're seeing more about this as people get ready for vaccines. That's where I'm going here with this. So I always, the CDC in the United States, I have to say, I love that they make infographics, and they're usually out of the gate first. I have to hand it to them. So I noticed when I was preparing for this, they've got a nice one on older adults, if you ever wanted to show something, and I'll try to find a Canadian one for you. But basically it says scientists are working to develop the vaccines, but these are the people at risk, especially those with pulmonary frailties, COPD, lung disease, cardiovascular frailties, and immune compromise. And they make the point, RSV is dangerous for certain adults. And this links to Stephanie's mask comments. In a transplant patient, they get a respiratory virus and maybe their FEV1 decreases or they reject an organ. The stakes are different in different populations with viral infections. So we, as the clinical group here, I know you know this well, but it's good to see a spotlight on this. And they do put some numbers, deaths in older adults, 6,000 to 10,000 estimated per year in the US. So wouldn't it be great if we could prevent it? You'll see systematic reviews. People are trying to get some information. If you want to look at what's been published about some of your niche populations, those of you in adult medicine, you'll find citations in this review. So the main reason to speak about this now is we've got people's attention on respiratory virus. So this is a moment opportunity knocks. We want to be able to let some good come out of this pandemic and apply what we've learned through SARS-CoV-2, our increased testing, and what we do with influenza to other pathogens like this one. And there are at least 7 prevention products expected fairly soon. So there's going to have to be program planning if all of these come to fruition, if they have to first be proven safe, effective, and authorized for use. But there's lots of potential here, which might really change our landscape favorably. And then the final point, of course, is the things we just spoke about, the vulnerable patients right in front of us. So we knew this was coming. These are some colleagues from the National Advisory Committee on Immunization that published this in April of 2020. So in the start of pandemic, there was a lot of work to say we need to bolster the information we have out there to have the numbers to show the impact. And it looks like they basically surveyed provinces and territories, found out which type of surveillance data we already had that would let us look at good outcome measures. And the gaps were Indigenous communities, remote communities, and older adults. We're still not clear on incidence. So this was sort of a call for better data, and I think the time is now. I'm now just going to close with vaccines. I want to, unfortunately, just point out that there was a historical attempt at vaccines for very young children in the 1960s. And this protein vaccine adjuvanted product, unfortunately, it resulted in a higher risk of infection and a severe inflammatory response. So devastating. But what has been learned from that is that the protein that you need to fuse to enter the cell has 2 conformations, and there's an antigen that can be targeted in that pre-fusion protein form that is a target that would give you a neutralizing antibody. So you have rational vaccine development in this era looking at these epitopes. So that the important learning has come from that. And so for all of you trying to make sense of the science by press release, which I see is happening, there seems to be a huge competition in industry right now on this topic. Or the headlines, you're seeing phase 2 trials, phase 3, you're going to see these publications coming. If you want to make sense of that, I refer you to this publication, Lancet ID 2023 by Mazur and colleagues. It really has some nice graphics to put it all in context, show you it's recent, shows you where things are at. What they're showing you here is we have passive immunization agents for the very young infants, those who might not respond to vaccine and so on. Maternal vaccination, phase 3 trials, Pfizer's maternal vaccine to immunize the mother to indirectly protect the infant. And then in older adults, there are several products. These, you can see IM meaning IM injections, but we've got protein products, viral vector, mRNA vaccine from Moderna. So this is a hot space. And that review that I've listed there is a really fulsome summary. The monoclonal antibodies, just to let you know, this is more in the realm of pediatrics. So if you're not up on this, I thought I'd just mention it. Palivizumab is available, very expensive. It's an injection every month throughout the season. It is recommended for those very high-risk infants, so really premature. You can read all the details in the National Advisory Committee on Immunization statement from last summer. But that has benefit in select populations, and it's not convenient and expensive, quite frankly, when we could make it better kind of thing. But nirsevimab is currently submitted. It's not yet authorized, so this is under review. But this one is a long-acting, so it would be 1 dose. You'd have to have a seasonal virus, which we do here, I would argue. So you'd give it before the season to last the season. The cost, that is a really important question. But the endpoint in the study was for all infants. So imagine if you had an agent you could give to all healthy infants safely. And their primary endpoint, and there are several, was medically attended lower respiratory tract infection. And it's interesting to think about what impact this might have if it comes to fruition. This is the last slide on these vaccines for adults. all of these candidates, one of them is already submitted just very recently, but submitted to Health Canada for review. So, you know, to be clear, they still have to finish these important trials. They have to have demonstrated safety. They have to be proven effective. All the details need to be considered. They need to be authorized and so on. But this landscape might change dramatically. And so we really wanted to sort of alert you to that through this talk. And then I've also mentioned vaccination for those who are pregnant, with the angle that you would be indirectly protecting your infant. So with that, I'm going to conclude. I think I hit that I paused. Did I do that? I'm not sure. I hope you can still see it on Zoom. Anyway, so lots of viruses. We're back on track. We have lots of prophylactic items in the wing. And thank you so much for your attention today. We'll close.
Thank you, Robyn. We really did have, honestly, 2 grand rounds worth of material today. So I do want to applaud the group. No. It was a lot of great stuff there. So some of the questions have already been answered online. There's another question, Lynora, if you're still online, you can answer that last one with Paxlovid. But because it is, we're at time, I do want to again thank our 3 speakers. Thank you for that. There's hope on the horizon for RSV, because you're absolutely right. There's a huge burden of disease, so that's exciting to see. I just want to give an announcement for next week grand rounds. We have Dr. Miles Marchand. He's actually a cardiac fellow at UBC, I believe, talking about Indigenous heart health, perspectives of a First Nations cardiology fellow. He will be presenting remotely. We still have the audience here. We have coffee here, but just so you know, the speaker is remote. So again, thank you, everyone, and I wish you a good weekend.
Thank you.